All right, so it's nice to get to meet everyone at least remotely. I'm Rory Abrams. I'm one of the neurologists here. I did my residency and fellowship training at Sinai as well. I specialize in general neurology as well as peripheral neurology, neuromuscular disease. And so what I wanted to really talk to you all about today was give a really just, overview of really common diagnoses you guys are going to see all the time, whether you're going into, internal medicine or some other subspecialty. You're going to come across this. You probably have, maybe some of you have carpal tunnel or other things like that. So I'm going to talk to you about like helpful tips that you can use. And yeah, so I want you to feel free to, ask questions, stop me, but hopefully we'll have time at the end if anything comes up. What I'm going to focus on is, some helpful tips for history taking, what you're going to listen for from patients, and then the specific disease entities I'm going to go over is radiculopathy, compressive neuropathies, polyneuropathies, some of their workup and management, and then just some key takeaways. So I just wanted to start with a few cases. These are all real patients that I've seen in the last month or so, and just like represent some of these different entities. So my first case, 41-year-old right-handed female with asthma, Crohn's disease, obesity. She's on Eliquis for DVT. She's complaining of left hand tingling, burning, itching pain affecting the thumb, index, and middle finger. Her exam shows decreased pinprick sense on those fingers, mild weakness of the thumb. And she says that particularly it's bothersome to her at night when she's sleeping. It wakes her up at night. She's having to shake out her hand, get up, walk around. She puts it under cold water to make it feel better. And her PCP recommended that she wears a wrist splint. And she was doing this for some time, but she's sort of inconsistent with it. And so she said to me, I think something else is going on, and that's why she came in. So what does this sound like to everyone?
Carpal tunnel?
Yeah, it sounds like a carpal tunnel. Her risk factors are probably the obesity, but this happens in people of all ages. Rare people in their 20s and 30s, but it happens, can happen very commonly with pregnancy. We'll talk more about it, but yeah, so I did an EMG on her. She had a very mild median neuropathy at the wrist. And that's what she had. Case 2, 19-year-old right-handed college student. She had no medical history, and what she told me was she's been having bilateral arm and hand paresthesias and pain. She said that it really started March 2020, although probably it went back even further into 2020, but in March 2021, she had first right-sided, followed by left-sided tingling affecting the fingers, mostly in sort of this aspect of the ring and pinky fingers. Her exam when I saw her was completely normal. What was interesting was she, I asked her, what were you doing at the time this started? She said she's a computer science major, spending a lot of time on the computer. Everything is remote learning. And she was typing and writing a lot for midterm exams. And that's when it was really bothersome to her. She saw some neurologists near where she was. I think she's studying in California. And the neurologist said, try some wrist splints. She did that and didn't get better. And so she came to see me for another opinion. What does this sound like?
Ulnar nerve impingement at the level of the elbow?
Yeah, probably it's ulnar nerve impingement at the elbow. That's the most common site. This was her EMG that I had done. So I took a quick screenshot of my EMG report. I'm not going to go through how to read these. That's a whole other talk. But sometimes you'll get sent these reports and like, how do I read it? Well, it's helpful when things are bolded in yellow and that's what's abnormal. But if you, the median studies were completely normal. She did not have carpal tunnel, but her ulnar studies showed these normal velocity in the upper extremity. This column is velocity, where I'm mousing over. Normal is anything above 50. She had 29, 27. This is across the elbow, this segment here. So she had focally slowed conduction velocity. So we would say it's either demyelinating or there's a focal neuropathy at the elbow. She was very thin. She's probably typing and leaning on her elbows, and that's what it is. Super common during the COVID era. Everyone's leaning and sitting more. We're all sitting more than we've ever sat before. Case 3, 43-year-old right-handed female, history of GERD, remote motor vehicle accident in 1997. This was complicated by multiple herniated discs. She's had multiple spine surgeries. And she says that 2019, she developed a right foot drop. And given her history of lumbar disc herniation, a surgeon said to her, you should go back for a revision surgery. She tells me that they did the surgery at L5 and cleaned up L4 as well. She thinks that the foot drop may have slowly improved a little bit after that surgery, but she's still having numbness and tingling in the right side of the lateral leg and foot, but also has some symptoms on the left leg as well. And she frequently rolls the ankle. Her exam showed normal strength, but sensation to light touch, pinprick, temperature on the lateral aspect of the right lower leg, and foot was abnormal, and she has difficulty walking on her heels. Any thought what this could be? Does anyone think that this was from the spine?
Remember, guys, you can also write it on the chat as well.
So she, I did an EMG on her, it was completely normal. What I ended up doing was bringing her back for a nerve ultrasound, and I studied the perineal nerve, and what I saw was the nerve was focally enlarged in the perineal nerve as it crosses the fibular head. That's a very common compression site. So the same way we've talked about median nerve at the wrist, ulnar nerve at the elbow, perineal nerve at the knee, a very common site of compression that everyone should be aware of. Okay, case 4, 77-year-old right-handed female, history of hypertension, hyperlipidemia, diabetes, hypothyroidism. This sounds like probably a lot of patients you guys see all the time. She came in complaining of gait instability for several years, and she's experienced multiple falls. She denies any numbness or tingling in the feet, but endorses some low back pain. Her exam shows mild sensory changes, light touch, pinprick in the soles of the feet. So what do you think this is? To figure out how to bring up the chat. Okay. Someone wrote B12 deficiency, diabetic neuropathy. So a lot of people are saying neuropathy. Again, diabetes is an etiology. Diabetes doesn't mean you have to have neuropathy. Hypothyroidism can definitely predispose to neuropathy, as well as other issues affecting gait and balance. But actually, her nerve conduction study did not show any peripheral neuropathy. She had beautiful sensory responses, beautiful motor responses. But when I did my needle study, within the L5S1 distribution, she had denervation there. And so I said her study was most consistent with a lumbosacral radiculopathy. And so I recommended to the referring doctor that she end up getting some imaging like an MRI of the low back. Okay, next one. Case 5, 81-year-old right-handed male. He's a history of CLL, anemia. He had a prior stroke, and he's very active guy. Every time he tells me very cute, he's like, I have a girlfriend who's 20 years younger than me. She only thinks I'm 10 years older than me. And so he really wants to stay being very active with her. And he says, but what's bothering him is numbness, tingling in the feet, ascending from the balls of the feet to the ankles since 2015, 2016. He says that the numbness may be associated with tightness in the legs, maybe edema, he's not sure. But fortunately, there's no pain and there's no really gait imbalance, but it bothers him. And his exam shows length-dependent sensory changes to light touch, pinprick, vibration, cold temperature, proprioception, basically every sensory modality. So what do you think this is?
Did he receive any medication for SLL?
For what?
Did he receive any chemotherapy before for
For the
this?
CLL? No, I don't think so, no. But yeah, good thought.
Did he have a B12 anemia?
No. I think the anemia is probably secondary to the CLL. So someone wrote monoclonal gammopathy. I think that's a good guess. Any other thoughts? So I repeated an EMG, and he had an EMG from 2017. It showed severe axonal neuropathy in both legs. Fortunately, compared to 2020 from 2017, actually all of the amplitudes, all of the responses were actually pretty similar, maybe minimal progression, I thought. But yeah, in terms of etiology, I think whether it's not just an MGUS here. He has CLL. That's probably his big risk factor here for developing neuropathy. In the absence of him getting chemotherapy or some other, vitamin deficiency, we are going to talk about etiologies of neuropathy, and I'll give you a good list for workups that you can pursue. I think this is my last case. 68-year-old right-handed male with hypertension, diabetes, well-controlled HIV. He has remote cervical spinal stenosis, had spinal surgery for this. He had carpal tunnel release, and he was in his usual state of health until 2021. In terms of the summer, he says, and this is a very active guy. He says that he walks up to 10,000 steps per day, measured on his Fitbit. And then mid-August, he starts noticing very rapid onset, progressive bilateral extremity weakness. Started, I think, in the right leg and then progressed to the left leg sort of simultaneously, and with difficulty ambulating over 2 weeks. And as the weakness got worse, he started having burning, tingling, stabbing, shock-like pain in the feet. And really nothing really, to say why this happened. The only thing I got out of him was, he received the Pfizer booster, a couple of weeks before this started. So any thoughts on this? I see AIDP, syphilis. GBS. So what ended up happening to him, so he was first admitted to neurology here, transverse myelitis, and he got an extensive workup for all the things you guys are thinking of. He got MRIs, he got a lumbar puncture, he got an EMG. I think he had a normal protein in a CSF, normal inflammatory markers. His MRIs were normal. Definitely no new cord compression in the cervical spine. And based on his EMG, he was diagnosed with an acute inflammatory neuropathy. He was given 5 days of IVIG, which he says at least stabilized, if not improved his symptoms. And then he did acute rehab here. Then he went to SAR, and then he was discharged home. He came to see me 4 months later. He was in a wheelchair, but he says he's able to take a few steps at home with his walker. So he's at least improving. I think for him, his big risk factors are probably diabetes, probably HIV, and probably the Pfizer booster. Those were his risk factors for this happening. So I'm going to jump into talking about neuropathies. This slide, I'm talking very generally. This is what you should all focus on your history taking. Clues to this being a neuropathic process as opposed to something being orthopedic. People are going to describe more numbness, tingling, burning, pins and needles, electric shock sensations. If they're describing more pain with moving at a joint, you may think that's more an arthritic change. When you have this list of symptoms, you want to focus on, is this a focal process or is this a generalized process? Is it limited to one hand, one foot, one leg? Is it symmetric? Is it sort of generalized? You want to note how fast is it happening, acute or chronic? What happened first? When was the first symptom? Now did it sort of take off and getting worse quickly? Is there weakness associated? What's weak exactly? What movements of the muscles are weak? Is there pain? So as I mentioned, it's not pain at the joint, but it's these the tingling, the burning, these paresthesias, are they actually painful? Allodynia. Allodynia refers to a painful reaction to something that shouldn't be painful. It should not be painful just to brush the skin or brush the hair or touch the face. But if that's a painful, that suggests that it's a neuropathic process. Is there neck or back pain? Is there radiation of that pain from the back or from the neck down the arm or down the leg? And as you guys are really paying attention to, what are the underlying medical conditions that may predispose them to this going on? Everyone sees hypothyroidism or diabetes, you immediately say, oh, this can be a neuropathy. So, but these are clues you can use to help figure out what's going on. So I'm just going to talk very briefly about this. What exactly is the peripheral nervous system? I don't think it gets enough attention. The brain and getting MRIs, that always gets attention. But the peripheral nervous system, in case this shows up on your boards, strictly defined as the part of the nervous system where the Schwann cell is the major supporting cell. In the CNS, so the brain and the spine, glial cells are the major supporting cell. So what is included in the PNS? The nerve roots, the peripheral nerve plexuses, or plexi, the peripheral nerves themselves, the primary sensory neurons, primary motor neurons, and the neuromuscular junctions where the nerves are synapsing with the muscle. All of that is considered the peripheral nervous system. Very briefly, the primary sensory nerve cell bodies are in the dorsal root ganglion. That stuff in medical school is useful for something. Whereas the primary motor neurons, the anterior horn cells, are actually found in the spinal cord. They are technically part of the peripheral nervous system. And actually the cranial nerves, the 3rd through 12th cranial nerves are technically part of the peripheral nervous system. Cranial nerves 1 and 2, so what gives olfaction as well as vision, are technically thought to be part of the central nervous system. And again, this is based on what the supporting cell is, the Schwann cell, what is myelinating the cell. Just as a quick reminder, there's 31 pairs of nerve roots, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. You say, what is a nerve root? So this diagram here sort of showing the spinal cord. At each level, there are two portions feeding into the mixed spinal nerve. So you have an afferent circuit. So let's say you touch something hot, you touch a hot oven, that information, that sensory information runs up the arm, brings it in past the dorsal root ganglion where the cell body is, and it carries that information into the spinal cord. There's the motor horn cell, the motor root, carries efferent information, brings that motor information out of the spinal cord and down toward the arm to tell you to pull away from that hot oven. They form a mixed spinal nerve. These are the nerve roots that are emerging from the spinal cord in the cervical spine, thoracic spine, lumbar spine. So they form mixed, meaning it has both motor and sensory information. They then divide up into a dorsal ramus that gives innervation to the muscles of the back, as well as some sensation on the back, as well as a ventral ramus. This is what will run down, say, the arm, or run down the intercostals, or run down the leg. Any questions about this? So what is a radiculopathy? So radiculopathy refers to a pain syndrome that occurs from when this mixed nerve root is irritated. So what patients are going to describe are pain, paresthesias, sensory loss within the distribution of that nerve root. So wherever that nerve root goes, that's where pain is going to be transmitted to. The most common areas where this is going to happen is going to be the cervical spine and the lumbar spine. This is because this is where we're most mobile. Is it possible for you to have a radiculopathy in the thoracic spine? Sure, it's possible. Probably the most common manifestation of that you're going to see is shingles, where you're going to have that dermatomal pattern running around the ribs. So as opposed to it being a structural cause, which is by far the most common time someone has chronic neck pain, low back pain, they're going to describe sciatica. You're looking for structural causes, far more common. And what's happening in those changes is whether it's bony change, arthritic change in the joint, the vertebral discs, the cushions between the bones move out of place and compress the nerve. That's what's triggering the pain. But other things can occur to the nerve roots too. These are vascular organs. You could have blood supply be cut off, and that is the danger of having structural changes compressing the nerve, is that left untreated for a long period of time, you end up strangling the blood supply enough that even if you decompress someone, they may not recover their motor or sensory function in that distribution. And so the workups you should be thinking about when you suspect this is getting an MRI of the affected area, considering sending them for an EMG test to get information on how well the nerves are functioning. You can look up tables like this, for different nerve roots. So, I think this is helpful to just give a sense of certain syndromes you might see. So for example, the C5 and C6 nerve roots are going to have pain more radiating from the neck to the shoulder, maybe the biceps. C6 does travel down a little bit to the thumb and the index finger. And you could see how that might be confusing for carpal tunnel if they're saying, oh, my hand is tingling. Meanwhile, they don't have carpal tunnel. It's a pinched nerve higher up. C7 ends up radiating down more along the posterior lateral aspect of the arm near the triceps. It may radiate down into the middle finger. C8T1 will kind of mimic more of an ulnar neuropathy, run down the medial arm into the hand. So you can use these tables. This is why you've come across these dermatomal patterns to give a sense of the pattern that you might see where things radiate down. So C5 to the shoulder, C6 down more to the hand, the lateral forearm, C7 into the fingertips, C8 more medial fingertips. So sometimes you can use these patterns as clues. Same thing in the low back. You can use these dermatomal maps to figure out what people are, what possible level is affected here. And you can pretty accurately figure out, is this an L3? L3 is going to go more toward, oh, I have pain radiating more toward the groin and toward my knee, as opposed to someone who says I have sciatica running down the back of the leg to the buttock, down the back of the thigh. If they say it's going down to the calf, so you can see here S1, if it goes down to the calf and foot, it's more likely in S1. If they're telling you, yeah, the outside of my leg, my lateral aspect of the leg and toes are affected, you might say it's more L5. If they have a foot drop, you're more likely to say it's L5. These are just helpful patterns and clues you can look for to clue you in onto a differential. I'm not going to go through the lumbosacral plexus. That's a whole other talk, a whole other differential, and times you might see that. But these patterns should clue you in if this is something common or something much more severe than one of these. Any questions about radiculopathy before I go on to compressive neuropathies? Okay. So I'm just going to touch upon median nerve anatomy because I think that's really the easiest way to understand it. Everyone thinks about just carpal tunnel, but there's more than that. So the median nerve is really derived from multiple spinal roots, C5 to T1. And because it's such an important nerve, maybe you can argue evolutionarily, that's why it receives such rich innervation. It's what really what makes humans humans, what lets us have an opposable thumb is really this nerve. And so it receives multiple contributions from the different nerve roots. It's formed by the medial and lateral cords off the brachial plexus. And then it's going to run down the medial upper arm along the humerus. It's just medial to the brachial artery. It's basically parallel to the brachial artery just until it emerges at the antecubital fossa. There it's going to sort of diverge a little bit from the arteries and run under the pronator teres. There's where it divides into what's essentially what continues as the proper median nerve, and then what becomes the anterior interosseous nerve. And then the median nerve continues, the proper median nerve continues down the forearm, past the wrist, through the carpal tunnel, and into the hand. The reason I'm pointing all of this anatomy out to you, you're going to see things besides carpal tunnel. So someone may, have crutches and they have something pushing under their arm, or they may have a humeral fracture and then having symptoms in their hand, because the information has to go through somewhere. It's traveling down this nerve cable right along the brachial artery. You're going to have plenty of people who say, hey, I had a blood draw and now all of a sudden my hand is tingling. Yeah, maybe they irritated the nerve. Maybe there's a small hematoma there that irritated the nerve. And so you have to just kind of think of these things in your differential. I'm pointing out the anterior interosseous nerve as well. There is something called an anterior interosseous syndrome. They're very specific muscles, the finger flexors, that this controls, but there's no sensory component to this. So patients who present with this, you're going to hear like young people going to the gym, lifting weights, they're doing a lot of curls, and what's happening is the anterior interosseous nerve is getting compressed underneath probably the pronator teres, and they're actually getting what seems a little bit like carpal tunnel from irritation of the nerve there, can be from a blood draw as well. So these are something to think about. When we talk about carpal tunnel syndrome, syndrome is anytime there's a constellation of signs and symptoms that are, in this case, very classic. What's happening is, again, the median nerve runs under the transverse carpal ligament. It's running with the finger flexor tendons. And within this compartment, the nerve can get compressed. And once it gets compressed, you get secondary nerve swelling. So I want you to think about this as you're hammering in a nail and you miss the nail and you hit your thumb. What happens is your thumb, it hurts a little bit, but it's really once later on your nerve, like the thumb swells up, that's when it's painful. And so that's what happens with repetitive use. That's why you say a repetitive use injury. The nerve gets swollen over time through repetitive compression. So everywhere that nerve provides innervation to is going to be affected. The two main muscles in the thenar eminence are the abductor pollicis brevis and the opponens pollicis. Abduction is bringing the thumb out of the plane. Opposition is bringing your thumb and index finger, or thumb and index, or thumb and pinky finger together. This is opposition. That's what becomes affected here. And then you're going to get sensation innervated, affected to the thumb, middle index finger, middle finger, and the lateral half of the ring finger. So you're gonna have pain, tingling, pins and needles. You can easily test for a Tinel sign, just tap. You can check for a Fallon sign, reverse Fallon sign. Patients are going to describe a nocturnal preponderance of symptoms. And what you're really trying to stop in these cases with treating this is not just the pain, but you want to prevent them from developing weakness, that you've so impaired the nerve supply to the muscles that their hand is actually getting weak. This is probably the most important muscle we have in the hand, the most important nerve to control these movements. Again, sensation is the sort of distal aspect of the palm and fingers. The palmar cutanear branch, so the actual sensation of the thenar eminence is not from the median nerve after it crosses the carpal tunnel. It's actually provided before it enters the carpal tunnel. So sometimes you can actually check pinprick on the fingers and then go to the thenar eminence. It should actually be symmetric and normal here. You're going to see this on your patient's atrophy of the thenar eminence. That's going to be a big clue. So what should you do about it? The first thing is patient education. You want to tell people why this is happening. They're overusing their wrists, they're compressing here, they're flexing here, they're sleeping on the hands, they're doing too many push-ups, they're doing too much yoga. A lot of people say, oh, I'm doing yoga to help my symptoms. doing downward dog is probably the worst thing you could do for your carpal tunnel. You need to tell people to stop it. So modification of physical activity, get them wrist splints, go on Amazon, they're like $10, just type in wrist splint, carpal tunnel. You can give them a prescription, they sell it at most commercial drugstores, just wear it at night because it's the part of the day where they can't avoid that compression that it can help. When it's very severe, I refer these patients to orthopedics. Sometimes ortho will try a steroid injection first into the carpal tunnel to reduce that swelling as sort of either a temporizing measure or something to try to avoid them going on to needing surgical decompression. There are acute cases that may require it. As far as I know, there's no role for oral steroids. Some people try it. Some people try NSAIDs, B6. You'll read about all sorts of things. You can try it. I don't see there's a harm to using, oral anti-inflammatories. It just may not help. When it happens in pregnancy, usually it'll go away after the pregnancy. And just sometimes you'll have patients who will have carpal tunnel release and they get worse. It's going to be very important to send those patients back to their orthopedist because sometimes they didn't divide the transverse carpal ligament sufficiently enough, and they actually made the pinch point worse where there's still residual compression. I'm going to touch upon ulnar neuropathy quickly, derived from the CAT1 nerve roots, again, runs down the medial aspect of the arm, very close to the median nerve. But what happens is it runs around the elbow, under the arcata struthers, and then it divides through. You can feel this on yourself between the olecranon and your medial epicondyle. This is where the nerve runs. This segment here is really where the nerve is most commonly compressed and pinched, though it can be compressed at the wrist. It can be compressed anywhere along the segment. Again, crutches or some other injury, you need to think about this. People talk about, the cubital tunnel. The cubital tunnel proper refers to what's shown in the dotted line here, everything within the flexor carpi ulnaris muscle and tendon. That's really considered the very proper cubital tunnel, but really the compression could be anywhere near this elbow segment. And so sometimes people will get surgeries for ulnar neuropathy and they don't get better. It's because the compression wasn't really here in the forearm. It's higher up. And so if you actually dig in the literature, it's always hard to do a true controlled study with any surgical procedure, but the data really isn't favorable for doing ulnar nerve transposition surgery. It's not favorable for doing injections. It's really hard. These patients, this can be a tricky disease. You've seen patients like this who you look at their hands and you see this scalloped appearance where the first dorsal interosseous is. You see this very kind of deep sunken boniness to the hands. And they may not complain of anything. They may not even tell you about it. And you're going to notice it. Decreased grip strength, loss of dexterity. You're going to have weak finger flexors. The ulnar nerve supplies the intrinsic muscles to the hand as well, both to the thenar and hypothenar eminence. So this can pretty significantly impair the hands. Sensation, again, the volar aspect of D5, the medial aspect of D4. If they're having sensory complaints, they may have sensory complaints in the forearm. However, meaning radiation down from the elbow, but if they actually have sensory findings there, it may suggest that there's a lesion higher up because the medial antebrachial cutaneous nerve actually comes directly off the brachial plexus. You can test this very easily in the office, just tap there. If you trigger a Tinel sign shooting down the hand, that's pretty clear what it is. I'm going to move on to perineal neuropathy. Again, the L4 to S3 nerve roots contribute to the sciatic nerve. The sciatic nerve is the largest nerve in the body. About 2 inches above the knee, above the pop fossa, it divides into 2 branches, the tibial and the perineal nerve. The common perineal nerve then runs down the lateral aspect. The tibial nerve runs down the medial aspect. It runs around the fibular head. Just about the fibular head, it divides again into the deep and the superficial branches. And then they continue down. The deep branch provides more ankle dorsiflexion toe extension, whereas the superficial branch does more eversion movements, as well as the superficial branch gives more of the sensory innervation to the lateral leg and the lateral foot. The exception being that first toe web space is the only sensory branch of the deep perineal nerve. What patients may describe. So typically the onset of a perineal neuropathy, it's usually acute. It can be subacute over days to weeks. They describe weakness of foot and toe dorsiflexion, foot eversion. The lateral leg and dorsum of the foot are numb. They may be tingling there. You can trigger a Tinel sign by tapping at the knee. They may describe sort of a very vague pain near the knee. And what they'll describe is toe dragging, foot slapping, their foot is hitting the ground. It's affecting their walking. They may have a Trendelenburg gait because they're leaning toward the other side to swing the leg while they walk. The most subtle test, it could be very mild. You may not detect any weakness on your direct strength testing, but then when you ask them to walk on heels, they can't do it. So that could be a clue that that's what's going on. Your big differential here is going to be an L5 radiculopathy. So if you have a patient like this, you're never wrong to send them for an MRI of their low back just to make sure that's not what's going on. Because again, if surgery is necessary, you don't want to miss that in their back. That's potentially an emergency. It's very rare for there to be, a true emergency at the fib head. More often than not, the etiologies you're going to think about for perineal neuropathy, weight loss. This is commonly called Slimmer's paralysis. People who've lost weight very quickly or lost a lot of weight. And it's thought to be because you're losing the fat pad that's around the fibular head. And so there's less cushion between the nerve and the bone, and you're just compressing against the bone. Prolonged immobility. So you have a lot of critically ill patients in the hospital, someone coming off a vent in the ICU, and you see their feet are dropped. They wake up and they're like, I can't really move my feet. That may be a common theme you see. In the ambulatory setting, the most common thing is someone's telling me about this. They say, yeah, my leg is bothering them, and I'm literally looking at them crossing their legs. And I say, stop it. Like, that's what the problem is. Prolonged squatting. So certain exercises are just squatting. People are stuck in a position. Maybe they had rhabdo for some reason. They fell down on the floor. It used to be called strawberry pickers palsy for people squatting, working in the fields all day. But knee dislocation, ankle sprains, very, very commonly can cause a perineal neuropathy, and it can be very hard to tell. Are they weak from something else besides the ankle sprain? Because when you roll the ankle, the tendons literally yank on the nerve as your ankle rolls inward. There can be a ganglion cyst is very common. You want to tell people to avoid tight-fitting pants or skinny jeans. And then, so pre-existing, so if someone has a polyneuropathy and their nerves are already a little friable, a little susceptible to injury, that may predispose them to getting now superimposed perineal neuropathies or superimposed carpal tunnel, median neuropathies, ulnar neuropathies. So these are things to think about in these patients. When you see this, again, you may want to get them an MRI of their L spine, their lumbar spine, make sure there's not a pinched nerve in the back. Tell them, again, counsel them what's going on, avoid compression. You do want to get them an EMG to really confirm that that's the diagnosis. But you want to PT to strengthen the legs, get them an AFO brace to support the ankle. It's not just to help them with walking, but it's also going to prevent them from spraining their ankle and re-injuring the nerve. If you can't find a clear etiology, as simple as they're crossing their legs frequently, you may want to get imaging at the knee, either with an MRI or a nerve ultrasound to look at the nerve to say, is the nerve actually compressed or inflamed, or is there a mass there? In the last few minutes we have, I'm just going to touch upon polyneuropathy. This is the most common manifestation. either, so the most common manifestation of either acute or chronic polyneuropathy is sort of that length-dependent, distally symmetric stocking glove distribution. It becomes more common with age. Your history, again, should detail how the symptoms started, when it started, how fast it's progressing. Patients are going to describe numbness, tingling, pins and needles starting in the toes and then spreading to the feet. A quick word about small fiber neuropathy. Small fiber neuropathy follows the same pattern, starting in the toes and feet, following the stocking glove pattern, but it can be patchy. It can be that they have more pins and needles on the thigh or on the hands. It can be sort of migratory in that way and not necessarily follow this pattern. But what people are going to describe, the thing that people are going to use, the word they're going to use is burning pain. That's going to be the clue. And there's going to be sparing of any motor involvement. That's really the clue to small fiber. And the etiologies are basically the same with some caveats. Again, as neuropathy ascends and progresses over time, whether it's acute or chronic, you may then get superimposed focal neuropathy. So these patients start with some tingling in their feet 5 years ago, and now they have a foot drop. And this is why. So the things you're going to look for in your exam, decreased pinprick, vibration in a length-dependent pattern. To do this, turn on your tuning fork, put it on the toe, ask them if they can feel it, kind of move it up one joint at a time. Start at the big toe, go to the ankle, go up the shin, go to the knee. And if they say, oh yeah, it's getting more and more intense, or I couldn't feel it at the toe, but I could feel it at the ankle, that's a clue that there's neuropathy there. You can ask them to move their toes, bring the toes up, flex the toes down. That's a clue that there's a neuropathy there. Some red flags that to be aware of, acute onset, that's potentially a neurologic emergency. Most polyneuropathy is chronic. You have time to work this up and figure out what's going on. If it's acute, you need to think, what else is this? If this is a new symptom. Muscle atrophy should give you a clue. Maybe this isn't just a run-of-the-mill peripheral neuropathy. Maybe this is something more serious. Skin ulcerations, very important to look in between the toes, make sure there's no ulcerations there, nothing on the soles of the feet, because again, these patients can't sense that there's an injury there. You're going to look for, so Charcot was named for both of these foot conditions, right? So you have Charcot arthropathy, where you have such loss of nerve innervation and vascular supply that the arch of the foot actually collapses, the bones actually collapse, and you have a Charcot joint, as opposed to Charcot-Marie tooth disease, where this is a hereditary neuropathy, where you have these very characteristic, very high arches and champagne bottle legs, very thin looking legs. But sometimes, this is the most common, Charcot-Marie tooth, the most common hereditary neuropathy. It's very common, but the only findings people may have is just a little bit high arches, and maybe it never bothered them until their 60s or 70s that they're like, yeah, I have some numbness. So rapidly progressive neuropathy, it's rare. It should prompt urgent evaluation. You guys all pretty much, sounds like, know about Guillain-Barré syndrome, rapidly ascending generalized neuropathy with numbness, weakness. You're going to look for in your CSF studies albuminal cytologic dissociation, normal white blood cell count with elevated protein, and it's often attributed to the post-infectious or post-vaccine setting. I like this term better than calling things AIDP. AIDP, acute inflammatory demyelinating polyradicular neuropathy. Yes, that tells you what it is, but not all Guillain-Barré is demyelinating. There's axonal variants. And so I don't love the term AIDP quite as much. I'd say, what is your diagnosis? Guillain-Barré syndrome, and the treatment is going to be the same. IVIG or plasmapheresis. You do not use steroids in acute neuropathy like this. In CIDP, there is a role for steroids, but your mainstay even there is going to be IVIG or sub-Q IG. So in the last couple minutes, etiologies. Metabolic diabetes, by far the most common, at least a third of cases, diabetes you want to look for. Hypothyroidism, chronic kidney disease, chronic liver disease. A whole slew of vitamins you want to think about. Certainly if they've had gastric bypass or some other absorption issue. Thiamine, very commonly. B6, interestingly, everyone thinks low B6 causes neuropathy. That's true. It's typically a small fiber neuropathy. People are going to describe burning and pins and needles. But also excess B6 can cause this. So don't just blanketly tell your patients take a B complex. I've seen, especially in COVID, a lot of B6 toxicity, and I have to stop all of that stuff for people. And then their symptoms go away, especially because we're all so health conscious. B12 deficiency, very commonly. B12 deficiency, B1 deficiency can even be a very painful neuropathy acutely. E, copper. With copper, you're going to look for people who are taking excess zinc. So people taking all these zinc lozenges, people with dentures, there's a lot of zinc in denture cream. You want to think about that. Alcohol, very common. Alcohol is directly toxic to the nerves. Not only that, it causes the B1 deficiency. So they have a double hit process. Chemotherapies, very commonly, vincristine, cisplatins, taxanes. You want to know about this, especially if your patient is going to be getting another round of chemotherapy. It may affect what regimen the oncologist recommends, because if they get 1 or 2 infusions and it triggers horrific neuropathy and pain, they're not going to tolerate that course. Autoimmune conditions, rheumatoid arthritis, lupus, Sjogren's, sarcoid, HIV, Hep B, Hep C. HTLV 1 and 2, very common in South America, Caribbean, asymptomatic in most people, but causes hereditary spastic paraparesis, but can just cause an isolated neuropathy, paresthesias as well. Paraproteinemia, so we heard about MGUS, myeloma, primary amyloidosis, hereditary causes, Charcot-Marie tooth, hereditary amyloidosis, this causes heart failure, kidney failure, cataracts, carpal tunnel, and it runs in the family. You want to be aware of this because now we have multiple mRNA silencing drugs that can treat this. And then about a quarter of cases are idiopathic, and despite looking for these things, you're not going to find a reason why. These are sort of a laboratory workup you can think about: A1C, TSH, ANA, celiac panel, your vitamins. I put vitamin D on here. I don't think of vitamin D as necessarily causing neuropathy, but if you took 2 patients with diabetic neuropathy, one had a normal vitamin D, one has a low vitamin D, the patient with the low vitamin D is more likely to report pain from their neuropathy. So supplementing vitamin D through the calcium regulation can be helpful. You want to check their serum or urine immunofixation, Lyme, HIV, Hep C, syphilis, check their rheumatoid factor, SSA, SSB. Sometimes we do all these things. We can't find a cause and people are getting worse. Send a paraneoplastic panel. Sometimes those panel of antibodies are attacking the nerves. There are genetic testing panels through several companies. A lot of time the genetic testing is free. It's sponsored testing. You can do these tests for free. That's really helpful for people. So you don't have to run through the whole insurance gamut. Hey, I want to test my patient for Charcot-Marie. Other parts of your workup, sending them for nerve conduction and EMG study. If that's normal and they're still having burning, tingling, pains or symptoms, that's when we would refer them for skin biopsy to do small fiber evaluation. I do these in the office if anyone ever wants to see that. You might send them for autonomic function testing if you think there's a small fiber predominant neuropathy and they're having any orthostatic symptoms or orthostatic intolerance. CSF testing really is only useful for things like GBS or CIDP. Otherwise, I don't really use it for any other condition. And you want to think about cardiac evaluation in certain cases, particularly your hereditary neuropathies. You want to think about with those. I think this is my last slide in the last minute. Treatment of neuropathic pain. Really, again, the reason that we're trying to identify the cause of the neuropathy is you want to try to prevent it from getting worse, if not reverse it. Otherwise, there's no great treatment to trigger the nerves to regrow. Please do not let your patients go to some other country to get, some unregulated, untested stem cell treatment. It's just, we're not there yet. I think that may be in the future, but we're not there. So what we have to do is kind of work with trying to improve their symptoms through, conservative means. You identify the cause, you supplement, you make sure they're nutritionally doing very well, control their diabetes, control their other risk factors. And then if they have pain, you treat their pain. So just because someone has neuropathy doesn't mean they need something for pain, but you should be comfortable, treating it. So probably the most common medicine I prescribe and that is prescribed is gabapentin. It was originally invented as a seizure medicine. It works actually not through GABA, but through regulating calcium channels. Really, the effective doses for seizure control are in the thousands of milligrams. You don't necessarily need that much to control nerve pain. Generally, for my patients who are, say, under 70, I probably start them on 300 milligrams of gabapentin right away, and have them titrate that up like weekly. But you can even up titrate that daily, 300 day 1, 300 twice a day, day 2, 300 TID day 3. And then you'll gradually increase it thereafter. In an older patient or someone who has renal dysfunction, you're going to start lower. Those are the patients you're going to start at 100. But don't be shy with the gabapentin. That's probably the number one thing I see is someone said, yeah, I tried gabapentin and it did nothing for me. And they're like 40 years old, have no medical comorbidities, and they were given 100 milligrams of gabapentin. Of course, it didn't help them. And they're just suffering with this. Pregabalin or Lyrica, starting dose, usually I'd say 75 milligrams of pregabalin is like 300 of gabapentin. So in your older patients or patients with renal failure, you might start this at 25. The half-life of these medicines is about 8 hours, so that's why there's TID dosing. And usually I try to optimize one of these first. Never put them on both medicines because there's no point. They work on the same pathway. Pick one, optimize it before you move on to your second line agent. So usually I'll pick second line, either an SNRI or tricyclic antidepressant. The two big ones are duloxetine, which is Cymbalta, venlafaxine, which is Effexor. The things to know about these medicines, GI discomfort, that's what really limits their use, as well as sedation. They can be very sedating. Generally, I try to tell people with duloxetine, start it before bedtime. Venlafaxine can be a little bit activating, so maybe this one they can take in the daytime. Venlafaxine can be harder for patients to discontinue. It can trigger a lot of paresthesias to come back if they ever need to discontinue it. For tricyclics, amitriptyline or nortriptyline, usually start this at either 10 or 12.5. You can prescribe them 25 milligram pills, tell them to break it in half when they first take it. It can be very sedating. I took it last year when I had shingles. I said, oh, I'm a guy, I'm fine, I'll take the 25. I was like drooling on my couch. Really start slow with these, and then you can go up higher. Usually I kind of limit it to 50 to 100 milligrams per day before I try to find them something else. You don't necessarily need to go to the antidepressant dosing in like 200, 300 milligrams to help control their pain. And so you want to be careful given the anticholinergic properties in older people, especially if these people are admitted with altered mental status. You want to stop this right away. Cannabinoids, your patients are going to tell you about this. That can be very helpful to at least take the edge off. I don't prescribe it, but now that it's legal in New York, why not? Lidocaine patches, 4% over the counter, 5% by prescription. It's only approved for post-herpetic neuralgia, but it's a really nice topical agent with no real systemic side effects. It can be associated with a rash at the site, so you just have to make sure they're changing out the patches every 12 hours. So 12 hours on, 12 hours off. Capsaicin, another nice topical agent. It's sold over the counter in very low concentrations. They can apply it between like 4 and 8 times per day. What limits it, it's burns. They have to make sure they don't touch their face, wash their hands really well before they go to the bathroom, because it burns. Capsaicin is pure chili pepper oil. But that burning sense is what led it to become a therapy, basically downregulating the small fiber receptors. It's now approved in a high concentration 8% patch for postherpetic neuralgia and diabetes. It failed trials for chemotherapy, as well as for post-surgical pain, as well as for HIV pain. Sometimes people get it approved and try it, but you limit it to the feet, and it's every 3-month application in the office. There's no systemic toxicity from this. Opioids, people are going to ask you, hey, can I have an oxycodone for this? There's no role for opioids for chronic pain management from neuropathic pain. Maybe for acute management, while you're titrating some of these up, you may want to try some of these. You know, someone has a short course of shingles and they're miserable, or after surgery, fine, but really that's not what we should be doing. We should be looking at these other options. Just in the last minute, all of these neuropathies, very common. Length-dependent neuropathy can lead to increased susceptibility to superimposed focal neuropathies at the common compression sites. About a third quarter to a third of polyneuropathies are idiopathic, but we should try to figure out why they have it to prevent progression. First-line treatment for compressive neuropathies, patient education, splinting to avoid further irritation, and then just to be aware of what's out there for treating neuropathic pain. And with that, I will stop talking. I thank you for listening, and I just want to thank all of you for everything that you're doing for our patients. I know this is a really hard time, but you're doing really good things for the world, and you should all just be very proud of where you are and what you're doing. So with that, if there's any questions,
Okay. So if there aren't any questions, thank you so much for your time, Dr. Abrams. It was a great lecture.